Hello, friends. First of all, I welcome you to the 4D 3.0 program, where we'll be talking in detail about discussing regarding the diabetes and especially targeting regarding Indian diabetes. In this unique program, we would try to look at the challenges that are associated with treating our patients and some particular parameters that can help us identify these solutions. For these, I have a team of three dynamic doctors who are from the software capital of India, that is Bengaluru. And first of all, I would like to call upon consultant nephrologist Dr. Kritika Murlidhar to please join me.
Yeah,
So,
thank you,
hello.
sir, for that introduction.
Yeah,
Yeah,
she's a consultant nephrologist at Sagar Hospital, Tilak Nagar in Bengaluru. So
yeah, that's
Bengaluru,
it.
I think it's known mostly for the IT thing. But beyond that, what is it that you like about Bengaluru? Because I personally like the weather and I hate the traffic. But is there anything else that you particularly like about Bengaluru?
Yeah, I think I've been kind of brought up here, so it's like a hometown. So the weather is the most important thing everybody loves, and the food that we get, the varieties.
Okay.
And I think now it's become a cosmopolitan city, so that's also great.
Okay. So when we talk about food, it has to be about diabetes. And when we talk about diabetes, we have Dr. Praveen Gangadhara, who is a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center in Bengaluru. So welcome, Dr. Praveen. And so, what is special in Bengaluru food that you like about? That is the first question that I would
First of
like to
all,
ask.
at the outset, thank you, Ashpal, for the kind words and introduction. And it's my honor to be part of this wonderful team. And I would align with Kritika there. And we all love the weather. And the best part is the food. And you get, and if you ask me, my area in specific, you would probably be in our school days, we used to have a fight, North Bangalore versus South Bangalore. And we used to always talk about the right from dosas to idlis, which is better, CTR or Vidyarthi Bhavan. But at the end of the day, we are a carbolic. That's the other challenge we all face. We are flooded with carbs, and with cosmopolitan trend, I think only the variety of carbs has increased.
Right. So
Refined
I think
carbs.
true, absolutely. And when refined carbs, I think it's not far away that the organ of heart that comes close by. And for that, I think we have consultant cardiologist Dr. Vikram Patil, who works at Kaveri Hospital, Bangalore. So yeah, so after asking Dr. Kritika and Dr. Praveen what they like about, other than traffic, what is it that you hate about Bangalore?
Yeah, I thank you, Dr. Ashpal, for the introduction. Nice to join the team here. Yeah, other than that, I think I hate pollution as such in Bangalore.
Okay.
So again, obviously, it's an outcome of the traffic what we have.
So I think pollution is an important part that actually is covering most of our cities. So today I think we'll be talking about obesity and its associated complications. So I think there's an old adage in English that says that actually we are digging our graves with forks and knives, and it's very true when it comes to obesity because it's a common problem, it's a common myth, and obesity itself is a chronic multi-system disorder. Initially, it was thought to be just a cosmetic issue, but now we know that it not just covers the cosmetic part, but it has its multiple variables and variable tentacles that it faces regarding obesity. So, the first question that I would like to ask Dr. Vikram would be so, why do you think obesity matters in the field of cardiology, and why do you think it is important that we focus on obesity per se?
Yeah, like you rightly said to begin with, so obesity amplifies a lot of cardiovascular risk factors like diabetes, as well as hypertension, dyslipidemia. Also, obesity itself can lead to various other problems like they are prone for heart failure, and also associated with that, reduced physical activity and other things are likely to lead to increased incidence of cardiovascular disease in the long term. So obesity is an underlying commonality amongst all of the lifestyle diseases what we see, and as we see, we are becoming we are already a diabetic capital of the world, and slowly we might end up becoming the cardiovascular disease capital as well, looking at the rate at which we are having cardiovascular diseases, especially in the younger individuals. So a
Okay.
lot of younger individuals we are seeing who come with heart attack and hypertension in the end. So considering
Correct.
all this, I think obesity is a very important risk factor which needs to be tackled appropriately.
Okay. So not just far behind the cardiac issue. I think now we talk about what we call it as the CKM milieu. So from cardiac, then next comes the kidney. So Dr. Kritika, your take on why obesity per se would affect kidney per se, and what would be the direct correlation with the kidney issues that you face and what you are looking at?
Yes, Dr. Yashpal. As you rightly said, the old term metabolic syndrome, metabolic X has all syndrome X has all been changed to now the CKMS syndrome. So the kidney plays a pivotal role because it is also an endocrine organ, and as we know that diabetes and hypertension are the leading causes for end-stage renal disease, the most common causes. Obesity has also been implicated as an entity which can be an independent risk factor and has a direct causal effect on kidney health. So here there are many mechanisms by which the adipose tissue can affect the kidney and its pathways. Most importantly is the hemodynamic mechanism where because of the state of volume overload, the sodium absorption and the increased adipocytes, they secrete angiotensin and that causes increased tubuloglomerular feedback and causes a state of intraglomerular hypertension. So that intraglomerular hypertension causes hyperfiltration injury to the kidneys, which causes protein leak, which is we see as albuminuria, and that itself is a risk factor for the cardiovascular health. So other than that, the adipocytes also secrete adipokines, which we know, and those adipokines, like which we commonly know, the leptin and the adiponectin, the imbalance in these things causes oxidative stress and it causes direct tubular damage in the kidneys. So that is one other thing. And the other thing is because of the excess adipose tissue, the increased insulin resistance causes a state of hyperinsulinemia. And this hyperinsulinemia itself, like how we know it causes beta cell toxicity, the same way in the kidney tubules, it causes tubular damage, and most importantly, it causes effacement of the food processes. So that causes the leak in the glomerular filtration barrier, which causes proteinuria and protein leak. And also the hyperinsulinemia causes increased production of transforming growth factors and collagen, which promotes fibrosis in the kidney. So it all perpetuates, and ultimately the hemodynamic stress causes glomerulosclerosis, which we see as obesity related FSGS, and the chronic tubular damage and fibrosis ultimately leads to the nephron loss of the nephron mass, and that causes progressive injury and damage and leads to CKD in various stages and ultimately into the state of dialysis.
So I
So
think that's
obesity, I mean, that's the way it affects the
So
kidney.
I think that's an important point that you spoke about, that because earlier obesity was only looked in the context of just cardiac perspective and metabolic perspective, but kidney is equally an important organ which is equally being crushed when you have obesity. The next question that I would like to ask Dr. Praveen over here is when we talk about kidney per se, or when we talk about obesity per se, what do you think are the endocrine implications of obesity? And what are the metabolic consequences that you are looking at?
I think Dr. Kritika as well as Dr. Vikram sir have briefly obeyed, but the main important factor here is obesity is kind of a mother of all problems there. If you see, if you can, even when you talk about the treatment perspective, things have changed from an upstream approach and a downstream approach, we tell, in the sense any amount of healthy weight loss or any amount of healthy weight loss has a kind of a beneficial effect in terms of the diabetes or blood pressure control or the cardiovascular outcomes. And today we see more and more even the therapy also being to tuned in this way. When you're speaking about obesity as an endocrine problem, in fact, it is increasingly recognized that the word obesity itself is being replaced with adiposopathy, which is again kind of again a problem with the adipocytes, dysfunctional adipocytes, and again the redistribution distribution of these adipocytes in the body plays a very important role. And sometimes why some people respond to diet exercise, but there is kind of a resistance when they don't they kind of reach a plateau with the lifestyle modifications, and somewhere why you require some of the pharmacotherapies in some of these people. And as rightly mentioned, again, when you talk about the the endocrine aspects here, I think again we need to get a little bit slightly into the genetics, and we as Asian Indians are a very high risk population. When you talk about obesity, the Western guidelines basically focuses on your BMI, but here we need to think about BMI along with your waist circumference, and we have a much lower BMI cutoffs when you talk about obesity. So that is why in any BMI above 25 with waist circumference above 90 centimeters in male or 80 centimeters in female is considered abnormal. And this is kind of again associated with the kind of the old terminologies we used to use about the metabolic syndrome, fatty liver, or what you call as MASLD now. And again, that is also there is an increasing term called as fatty pancreas. Again, these are all kind of an entity which ultimately leads to increased pro-inflammatory cytokines, inflammatory pathways are activated, and again, this ultimately leads to I mean it's a two-way traffic there. High obesity will lead to hyperinsulinemia, then there is beta cell dysfunction, and again that leads to beta cell failure. And again, it's not just for the diabetes per se, but again the end organs, be it the heart, be it the kidneys. There's kind of a triangular series there which ultimately leads to the end
Absolutely.
organ damage.
I think we have started realizing that obesity per se is not a choice for our patients. It actually there are multiple things that come into play, and they finally get into obese. So initially, what we used to think is when person we see obese, so the first thing that used to come in probably that person is not just exercising. That's the reason why he's obese. But nowadays, now I think we have started realizing that it's a multifactorial disease that comes together when it actually sprouts into obesity. It is genetics, it's epigenetics, it's some cultural factors, it's some social factors, and all these factors come together then play an important role into this obesity. But an important consequence of this obesity is obstructive sleep apnea. So I think all of you would agree that it does contribute to both the morbidity as well as mortality that is associated with obesity. So first question I would like to ask Dr. Vikram Patel, he being a cardiologist. So can you tell what exactly is obstructive sleep apnea? Something in simple terms so that some people can understanding better, as well as why is it important to look at obstructive sleep apnea, not only in the perspective of obesity but overall in the perspective of cardiac disease.
Yeah, so obstructive sleep apnea. So as the name itself suggests, so there are brief episodes of apnea, especially during sleep, because there is an obstruction to the airway, so they are not able to breathe properly. So considering that, so it leads to brief episodes of hypoxia and sympathetic activation. So these are the mechanisms by which the obstructive sleep apnea leads to its consequences. So multiple episodes or prolonged episodes are the one which are likely to lead to their corresponding end organ effects which are there. So like we were mentioning, so obstructive sleep apnea is important to be screened and ruled out and also to be treated, especially in the individuals who are having hypertension in the young. And also we find that some people come with pulmonary hypertension, especially unexplained pulmonary hypertension which are there. So many times it is obstructive sleep apnea which leads to raised pulmonary artery pressure.
Okay. So I think that's an important point. So I think it has multiple cardiovascular implications which need to be noted. And just as you put your mobile phone to a charging or a battery mode, I think similarly everybody needs a good sleep, and good sleep gives you a good battery life to work for the next day. And I think obstructive sleep apnea actually causes unobstructed sleep, and that's why your battery starts spiking down. And that's probably the reason why I think it's an important thing that actually leads to an abnormal milieu. When you talk about milieu, I think the word comes as next is hormone. So I think Dr. Praveen, would you like to shortly enlist what happens or what are the consequences of obstructive sleep apnea leading to hormonal milieu, or how the hormonal milieu itself is disturbed because of this obstructive sleep apnea?
I think one unrecognized entity is obviously a disturbed sleep pattern has a long-lasting effect, be it your diabetes control. In fact, very commonly we see people with high fasting blood glucose levels, in spite of because That's again disturbs sleep patterns, increases your cortisol levels, and cortisol again we know is a counter-regulatory hormone. Again, it kind of increases your EGP or the endogenous or the hepatic insulin. I mean, hepatic glucose production. Your fasting sugar again starts going up, and again, increasingly in general with people with obesity, you tend to see a high fasting glucose, and again. Uh, yeah, again, the sleep disturbance or OSA again can lead to this issue, and not only just glycemic control, even the blood pressure control is also a big challenge in people who have OSA. So it's kind of a interlinking path, and I think definitely the in terms of the hormonal thing, we also again people with disturbed sleep kind of have a lot of cravings and they tend to eat more, again leading to adiposity. So it's kind of a vicious cycle with OSA. So treating the weight as well as the OSA is a very important point, and it's not something people. I mean, more than when we discuss about or take a history, we talk about snoring. We ask the respective spouse or I mean, whoever it is, but they tend to some of them are open to talk about it. Some are kind of brush it aside, and again, but it's a very important thing which we all need to assess when we take history in our people.
So I think Dr. Vikram has made a good point regarding the cardiac perspective. Dr. Praveen has made a good point regarding the metabolic perspective and stress that is associated with obstructive sleep apnea. But I would like to ask Dr. Kritika, that's some people are still surprised to hear. Would obstructive sleep apnea also cause some kind of damage in the kidneys?
Yes, very much. So what happens is the CKD has stages. So we say pre-dialysis, dialysis stages. You can classify them as such in patients with kidney issues because of the psychological impact and depression. They have insomnias, and the contributing factor apart from obesity itself is a problem of volume overload. So because they have a lot of fluid retention when they are not passing urine or their kidneys are not working, that causes palatal edema and edema in the pharyngeal muscles. Along with that, the uremic milieu, because of the increased toxins, there is a kind of a myopathy which happens and the muscles are weak. So our patients are definitely prone to this kind of sleep apnea syndrome. And in the pre-dialysis stages, what happens is because of the sleep apnea, like sir rightly mentioned, pulmonary hypertension, there's another entity of nocturnal hypertension where the patients we classify them as dippers and non-dippers. So physiologically, during sleep, you should be dipping your blood pressure by at least 20%. So if so we see in CKD and those with apnea that they are mostly non-dippers, so they don't dip their blood pressure during sleep, and this non-dipping are very prone to cardiovascular morbidity and mortality. So in our patients, set of patients, apart from the obesity per se, the volume overload, the muscular weakness or myopathy because of the uremic milieu causes more problems in terms of kidney and cardiovascular problems.
I think thank you for making those points because you really made an important point that I think dippers and non-dippers is something that is not talked about. And if you look at the kidney perspective, that's an important part because it's important that you maintain the overall vascular profile, and if that is not maintained, automatically that is going to lead to multiple issues that are there. So, Dr.
Yes, that's
Vikram,
the other
my
reason why we see sudden cardiac death in our patients, especially
absolutely.
CKD patients.
So coming to the same thread, I think so. Obstructive sleep apnea itself has some social issues. So recently, one of my patients said that doctor, I'm sleep divorced. So even I was surprised to hear that what is sleep divorce. So he said that we sleep in different beds at night because bedrooms at night because my husband snores a lot. So that's why we are sleep divorced. So this is just a social outcome, but I would first like to talk about the clinical outcomes in each entity. So I would like to first ask Dr. Vikram, what do you think are the cardiac implications of this obstructive sleep apnea, and what happens if we actually don't treat this sleep apnea? Because that's something that people say sleep apnea, yeah, it's something snoring, it's okay, can be treated, but what are the cardiac implications do you think would be? So one thing Dr. Kritika spoke about is the sudden cardiac death. But other than that, do you think there are more some cardiac implications that you think are important in relation to obstructive sleep apnea?
Yeah, definitely. So, with respect to obstructive sleep apnea, there are significant cardiac implications like we were discussing. So, one of the things is, as I told, so they are likely to have uncontrolled hypertension or resistant hypertension as well. and especially we tend to find a lot of young hypertensives wherein it's easily reversible by treating the obstructive sleep apnea. So many times we will be able to have a better blood pressure control. That's one thing. And other thing is in the especially the pulmonary hypertension. Many times pulmonary hypertension, we though we elevate a lot of other causes wherein like pulmonary embolism and other left right shunts and other possible cause of pulmonary hypertension. What goes undiagnosed is that the obstructive sleep apnea, which is easily treatable, and also subsequently the pulmonary artery pressures are likely to improve once it's appropriately treated. And also there is a significant sympathetic activation. There is some contribution to dyslipidemia as well. So these are all the important consequences which if obstructive sleep apnea is treated appropriately, all these benefits can be derived to many patients, which quite often goes undiagnosed and untreated appropriately.
I think we spoke about uncontrolled hypertension. We spoke about the pulmonary hypertension. But Dr. Vikram, do you also think that there is some association between arrhythmias and obstructive sleep apnea?
Yeah, definitely. So especially atrial fibrillation, incidence of heart failure preserved ejection fraction. So this there is a higher incidence of heart failure as well. So there is definitely an association with arrhythmias, especially atrial fibrillation and heart failure in long term.
Okay, so looking at the cardiac perspective, I think we are looking at refractory hypertension. We are looking at increased risk of pulmonary hypertension, also increased sympathetic activity, which actually causes increased chances of arrhythmias, and that actually may end up getting cardioembolic risk of cardioembolic atherosclerosis or cardioembolic stroke-like events, which also actually puts it summarizing what Dr. Vikram said. I would like to ask Dr. Praveen, what do you think are the metabolic implications? So you spoke about uncontrolled blood glucose levels that are commonly seen, or we are not able to control the sugars despite giving optimal treatment. Other than that, do you think there are some other issues that clinical implications of obstructive sleep apnea that you see in your patients, especially in the metabolic department?
I think the other common challenge, I think most commonly is, first of all, people with, in general, with obesity tend to have high requirements, be it the oral anti-diabetic drugs or your insulin requirement tends to go high. A common complaint you get from them is you would see my fasting sugar is not coming under control. You optimize the basal insulin, even then the requirement tends to go up. The other common issue is sometimes add on to that, again, because of uncontrolled diabetes, obesity, and other things, they have high triglycerides. It's kind of, again, an interlinked chain there. Other challenge is the hypertension. In spite of being on 2 or 3 antihypertensive, generally they tend to have above their target range. I think at the end of the day, once in many patients, if the sleep is corrected, more or less the blood pressure again starts coming under control. Again, after optimizing your drugs, but again, everything depends on the weight loss, the percentage of weight loss, as well as once the weight is corrected, I think the OSA symptoms comes down, and then again using CPAP, or again it all depends on the management of the problem. And unless you don't fix this, you would have more or one or other recurring issues with either glycemic control or blood pressure.
So, other than that, do you think, Dr. Praveen, is there some kind of association between hypogonadism and erectile dysfunction associated with obstructive sleep apnea? Is there some link that is there? Can you
Generally,
elaborate?
people with abdominal obesity tend to have a less amount of, again, free testosterone associated with hypogonadism. That is one thing. But again, long-standing diabetes also can lead to erectile dysfunction and other reproductive issues. But again, it's all a combination there. I would not completely implicate everything to obstructive sleep apnea. It's again because of the obesity per se, you tend to see these problems.
Absolutely. And I think, Dr. Kritika, other than the nephron injury that you spoke about, any other implications that you see of obesity issues that you see in your patients with, or clinical implications of obesity per se in your patients with kidney disease?
Uh, Dr. Yashpal, yeah, sorry, I didn't hear you in the beginning.
Yeah. So I said, other than the nephron injury, do you think any other implications beyond this that you see in your patients with obesity?
Okay, yeah. In terms of kidney health, I think obese people are more prone to kidney stones. They have a tendency to develop nephrolysis. That is because of the increased oxalate absorption from the gut. So that is one problem which we see. And features of volume overload, which we see as the renal function goes on declining. Apart from that, in terms of transplant patients, what happens is obese patients are generally taken as what do you say, relative contraindication for undergoing the surgery, because when you're obese you're not a good transplant recipient or a candidate, and so your waiting list goes on increasing. And even though you get a kidney, you will be landing up more with surgical complications because of the obesity, and that will lead to ultimately reduced graft functions. So that is in terms of the transplant patients. But other than that, in patients on dialysis, there's something called as obesity paradox. I think you would have heard of it. What they say is obese patients on dialysis specifically tend to have lesser mortality because it reduces the catabolic state and helps them to live longer. So women generally tend to do better on dialysis. So that is what we seen actually.
So, do you think there is some explanation for the obesity paradox, or is it just plain simple catabolism that is playing its role?
There are a lot of theories which are pro and against it, but when we clinically what we have observed, we feel definitely the catabolic state actually is better when you're obese, and that helps you to overcome many of those distress situations which patients on dialysis regularly go through.
So, a slight shift that I would like to make from the obstructive sleep apnea to per se obesity part. A question I would like to ask Dr. Praveen Gangadhara. This has very well been described, and it's more commonly described in Asians and in particular in Indians. So, can you tell us something about what we call it as sarcopenic obesity? So that's something that is more talked about us in as an Asian perspective. So can you enlighten us about what exactly is sarcopenic obesity and what clinical implications does it have in your patients per se as a diabetologist?
So I think there are two components in terms of in generally with the Indians we tend to have the I already mentioned about the thin fat phenotype. Again, the other important part in our people is the bone health. Again, we know that obesity per se, again, in the long run, will have issues with your mobility issues, musculoskeletal issues. But again, in postmenopausal women with increased risk of osteoporosis, again, the bone parameters is extremely important. What happens again, obesity per se they can be a varying change in your overall the muscle mass as well as with the decreasing bone strength. They're again prone for fractures. Again, they can have issues with increased risk of fall. This varying thing again when you talk about weight loss, there is also say some amount of the protein intake and the muscle training is not there. This disparity between the both also can be have a negative implications. So again when you focus in them, when you talk about weight loss, we should also talk about the importance of strength training as well as adequate protein intake, and also make sure that when you talk about again screening for the BMD board, especially in people with risk of osteoporosis, and appropriate therapies for osteoporosis is also equally important when you're focusing on this.
I think
And
that's
again,
an important.
one important factor is we use now, there is increasing use of GLP-1 analogs and SGLT2 inhibitors. Per se, mainly the GLP-1 analogs where you are using for the long-acting ones, which you are using the weekly ones, be it the semaglutide or the tirzepatide. One important thing which we see over a period of time is we talk about the muscle wasting or the sarcopenia is the other important thing. I mean, in the long run. So just it's just not about losing weight there. Equally, make sure that the muscle is also not lost.
So I think that's an important point that Dr. Praveen Gangadhara that you have made, that bone health is something that needs to be looked into because it has been well evidenced that patients with obesity also have high risk of fractures. They also tend to suffer more from osteoarthritis. They also tend to suffer from so-called typical aches and pains, and that's why they actually are more consumers of analgesics on a day-to-day basis than a person who probably is more healthier, and that also per se can actually lead to issues like kidney injury that is.
And not to forget the role of vitamin D deficiency, which is quite prevalent in our population. So these are again adds on to the entire spectrum.
Absolutely. So they do add on to the problem of obesity, obstructive sleep apnea, and overall its surrounding issues that are ranging from there. A question that I would like to ask Dr. Vikram Patel is, you know that each obese person, because we spoke about now that we know that it's not just a physical disease, it's a psychosocial, metabolic, cardiac, kidney disease. So counseling is an important part when we treat obesity. So any patient with obesity, first we need to counsel. So how is it that you actually put forth the knowledge in front of your patient that look, now your weight is really high and you need to really do something about your uh, obesity, or you need to do something about your adiposity. So how is it that you motivate? Because that's something that lots of us physicians still have an issue with, because these patients, although they are convinced that obesity is the problem, but they are not ready to work on it. So how do you counsel and what do you talk to your patients about it?
Yeah, so like you rightly said, it's very difficult this thing to put forth and ensure compliance with the patient so that they manage the obesity in the long term. So what I tend to usually talk to them is that not just about weight loss, and I also talk to them that what are the other benefits of weight loss and also being physically active. So another important point which I make to my patients is that, see, irrespective of weight, so it's not just about weight loss. Irrespective of the weight as well, if you're physically active, your general risk factors for a lot of lifestyle disease and also cardiovascular disease comes down significantly. So
Absolutely.
this is a point which I put forth, and also I tell them that, see, telling them directly that you have to lose 10 kg or 15 kg, which seems unsurmountable. So it's better I would tell them that you can just take time for about 3 to 6 months, and then accordingly plan for whatever small weight reduction or a better lifestyle change. So I would rather ask them to spend significant time exercising rather than just chasing a target of weight loss. So, but what happens in the long term is when they become aware of their own unhealthy lifestyles, their food, and lack of physical activity, obesity gets managed in the long term. And also, I stress upon the point that consistency is more important and moderation is also important. See, because when they're scared or when they have a cardiovascular event, they tend to go to extreme levels and they follow it for a few months and then they just come back to their usual unhealthy lifestyle. So what I stress upon them is to begin with, they should make lifestyle changes which are likely to be consistently followed in the long term, and there should be moderation in that, and let them be consistent. So my general dictum for my patients is start slow and then gradually increase their physical activity and whatever lifestyle change they want to make.
So I think that's an important point that you made over here, that I think we should give our patients small targets, some achievable targets. So don't give them a huge target of say that you have to lose 30 kgs and they actually then become frustrated. So give a target that they can lose 2 kgs or maybe 3 kgs, and that will make a significant difference in their life. The other thing that you talked about is small changes that they need to make. So it's like I think putting SIP in the stock market. So small SIPs, they keep on adding up. Similarly, I think if you make small changes in your lifestyle, I think and carry it for a longer period of time, actually that translates into much better outcome. After the counseling part, I think we have covered about the pathophysiology of obesity and obstructive sleep apnea. I think we also have partly covered about the clinical implications and a little bit about counseling. I think let's focus more now on the treatment part. So, first question that I would like to ask Dr. Praveen Gangadhara, that what do you think would be your ideal choice of starting in a patient, both in a resource constraint setting as well as in a patient who has no issues with his pocket per se. So, in resource constraint settings as well as in patient who also actually has a enough amount of money to spend on reducing obesity.
I think when we talk about management, I think apart from pharmacotherapy, the first and foremost, irrespective of what you are using, I think lifestyle modification definitely plays a very important role. But unfortunately, it more so remains on the paper and it's not consistent. That is the biggest challenge. I think the first and foremost is we need to think of, again, when you talk about obesity, apart from exercise, calorie restriction plays a very important role. And we all know that we are a carbohydrate rich country. I think carb restriction is something which is the first and foremost which has to be managed. Even you may be on the best of best drugs, but if your carb restriction is not there, then calorie excess will ultimately lead to one or other issues. Again, when you talk about carb restriction, one important part or misunderstood factor for the public is just swapping or changing cereals, and that's not going to help. If you have to reduce cereals, you need to increase your protein as well as your healthy fat, and that's where you'll be able to sustain low carb diet. And along with low carb diet, again, when you talk about management, I think even if you go with the guidelines, what has changed over the last 2 decades is the two landmark trials. One was Empareg with empagliflozin, which is an SGLT2 inhibitor. Other was the leader trial with liraglutide. These two post this, I think we had an ADA EASD consensus where we just need to not manage only the glucose levels, and we need to think per se in terms of the atherosclerotic cardiovascular disease or a diabetic kidney disease or even weight management. And that's why these two drugs have come into the forefront in the management of, just apart from, and even sometimes over and above metformin, though ultimately we tend to use in combination with metformin, which was primarily considered as the first line therapy in managing diabetes. So again, when you focus, you need to individualize. Individualization of the therapy is important. With metformin, you can think of, in a resource poor setting, one advantage in India is today we have SGLT2 inhibitors which have gone off patent. And in terms of the cost, they also have some amount of modest amount of weight loss, but more so important, has a positive effect in delaying the progression for diabetic kidney disease. Today, even with non-diabetes, I think some of the indications of the trials have shown its benefit there. And also in terms of heart failure, it's a class effect. Another important drug along with the SGLT2 inhibitors is the GLP-1 analogs, or you also have the dual GLP and GIP, which is currently available in our country. And in this family, we started with daily injectable liraglutide. Then we have also had dulaglutide. But in terms of one which has been a game changer and people know about in terms of the social media awareness is the semaglutide as well as the tirzepatide. And both these long-acting GLP-1 analogs, though cost is a big constraint, it definitely helps. And where it helps is, if you look into the pathophysiology, it brings down your cravings. It acts centrally, your hedonic and non-hedonic eating. The hypothalamus, it works on your hypothalamus. It lowers your gastric emptying. It also has some amount of beta cell protective action. The biggest challenge with the GLP, unlike the SGLT2, is the compliance, and the cost. And because of the cost, you cannot take it for 2 to 3 weeks or 4 weeks and stop the therapy. In fact, the benefits you would see over 8 to 10 weeks or 12 weeks. Continuing the therapy is one thing, and the GI side effects are always there. So you need to always start slow and then uptitrate the dosage. You can use parallelly both GLP along with the SGLT2 inhibitors, which has been a game changer, not only just for glycemic controls, but also for heart failure, as well as to delaying the progression of kidney disease. And using them in a combined approach again helps. But along with the pharmacotherapy, sustaining a low carb diet is also extremely important, and regular exercise. And exercise doesn't mean only walking. You need to have a component of aerobic as well as strength training, etc.
I think that's a good point that Dr. Praveen you made over here. And for the benefit of the audience, I would just like to mention a little bit about what he spoke about hedonic and non-hedonic eating. So I think first of all, we eat is for metabolic. That means we eat just to live. Then we eat for pleasure, and this pleasure eating is called as hedonic eating. And this is when actually eating becomes unhealthy, and this is what actually is cut off by different drugs like GLP-1, GIP-1. So this pleasure eating needs to go away, so metabolic eating needs to remain. So coming to metabolic eating, I think Dr. Kritika, there are some diets which focus exclusively on using purely proteins as a source. So would you advise such diets? I'm not talking just about in patients with chronic kidney disease, but in patients, in general, patients who just want to lose their obesity. So they focus on only replacing all micronutrients with just eating proteins. So I think you would have heard about something called as Atkins diet, which was initially very famous, or some other diets. Would you think that they're safe to use? And that's an important question that lots of patients do ask us. So what's your perspective on that per se as a nephrologist?
Yeah, actually, in my perspective, I would advise a balanced diet, which is very important. A pure protein diet is more ketogenic, and we know, and of late, we have seen people who are succumbing to these kind of diets, which are sudden deviation from the normalcy, which the body has been tuned for almost 30-40 years. So it's a balanced diet, which is important. And in terms of kidney, overall, beyond stage 3 and stage 3B, we generally advise a low protein diet. So, a protein diet in CKD would be a vegetarian protein to the maximum, which we advise.
So I would like to ask one more question here. What do you think are still gaps that still obesity per se is not associated to be with, a disease of kidney? So what's the gap going on? Because it's still a cardiac disease, it's a metabolic disease, but everybody says no, it's not a kidney disease. So I think what better can we do in informing our patients as well as physicians that it's itself is also a kidney disease?
Yeah, the point is most of the time the creatinine or the urine, simple urine test for urine protein itself is not done. We have seen patients who have been diabetic for 5-6 years and then they come up with almost stage 3 and beyond CKD. So, in the general, I mean, I think creating awareness about simple testing for albumin, urea, and at least once in 6 months test for renal functions like the RFT and measurement of GFR and using the heat map of CKD. Of course, it may be difficult, but knowledge and creation of awareness is most important because kidney is much lower down and always neglected part, which comes at the last stage and almost like the common final pathway, which we say all the time.
True. That's an important parameter that I think evaluating urine albumin creatine ratio in every obese patient is equally important because a HbA1c is usually ordered, a lipid profile is usually ordered, a liver function test is also usually ordered, a creatinine is ordered, but a urine albumin creatine ratio is usually not ordered, which needs to be taken into consideration when we consider most of our patients. So, Dr. Kritika, I would like to ask what exactly are the that you would like to keep in your panel when you are treating a patient, say with obesity and associated chronic kidney disease. Then the same question I would like to repeat with Dr. Vikram, and I would come with the same question with to Dr. Praveen. So we actually cover most of the aspects that are related to obesity. So when you are talking about obesity and a patient with chronic kidney disease, what are the drugs that you would definitely like to keep in mind in adding such a patient, or you think would definitely benefit such a patient?
The
So if you
treatment, you're asking me the
yes,
treatment?
in the treatment part. So say
Okay.
let's take for an example a patient with obesity, hypertension, and associated chronic kidney disease. So what definitely are the drugs that you would definitely like to keep
Yeah.
in such a patient?
So, a diabetic CKD, the first line of drug obviously now will be an SGLT2 inhibitor. Though the guidelines say beyond 30 GFR you don't use it, but we still use because it has non-renal benefits in terms of cardiovascular effect. So maybe with the modification of the dose, we still use SGLT2 inhibitors even in stage 5 on dialysis patients. So that will be a definite part of the management because it the most important action which we see is the reduction in the hyperfiltration injury because of SGLT2 inhibitors, and it causes diuresis, so it causes loss of water and volume, which helps in the hypertension management, and hypouricemia also, which is a part of metabolic syndrome, is add-on benefit from the SGLT2. So that will be definitely a important part of our treatment plan. And in those who are non-diabetic, I mean, and during all the DAPA, CKD, EMPA kidney trials, we have seen in the subgroup analysis that it has benefits even in non-diabetic CKD. So we are using SGLT2 inhibitors even in other form of glomerulonephritis, like because of IgAs or FSGS. So that is one important drug which we are commonly using in all our CKD patients now. And the latest thing, other drug which is the which we have started to use, especially if they're non-diabetic, as a upfront is the non-steroidal MRAs, which is like the finerenone, which we use. But the issues with finerenone in the later stages of CKD is the problem of hyperkalemia. Most of our patients are on RAS blockade, so an addition of finerenone causes potassium monitoring which is required. And I think a lot of patients don't comply to this MRAs because of the cost which we have seen. So these are the important two drugs. And with respect to GLP-1 one analogs, I don't have much experience, but in earlier stages of CKD, we use it. But in the later stages of CKD, because already there is issue with nausea and vomiting, they do not tolerate this GLP-1 analogs well, because as such, patients with CKD are generally having anorexia, decreased appetite. So that is one problem. And yeah, so the among the latest drugs, these are the ones SGLT2 and non-steroidal MRAs, which we definitely use.
Right. So that's an important take-home message over here that I think SGLT2 inhibitors, drugs that work on the RAS system, and non-steroidal receptor antagonists, which are something that we need to mainly focus in our patients with CKD and obesity. A same question I would like to ask you, Dr. Vikram, that what do you think would be your choice of drug in a patient who has obesity with say concurrent ischemic heart disease and associated hypertension and with diabetes? So what are the drugs that you would like to be him to be on that would provide him the most optimal benefit in, or rather the most optimal evidence based benefit that you can provide in treating his obesity as well as treating his other comorbidities?
Yeah, so the important drugs definitely I would try to include it will be SGLT2 inhibitors, because across the spectrum of atherosclerotic disease, as well as based on the LV ejection fraction, whether it's reduced ejection fraction, monitoring heart failure with reduced ejection fraction, all of them it has shown that. So
Actually, Vikram,
SGLT2 inhibitors will
your
hopefully,
sound is little low. Can you
Not
speak a
audible.
little?
so
Yeah,
so
you're not
SGLT2
audible
inhibitor
clearly.
will be the definitely the first one of the important molecules we will try and include in these set of patients, and also obviously will have a lower threshold to start statins as well in this group of patients, though it doesn't have a direct benefit, not be directly benefiting the weight loss as such, but mainly considering associated dyslipidemia. So SGLT2 inhibitors would be the important molecule which we prioritize, and also statins we will consider based on their lipids.
And the same question, if I pass on to Dr. Praveen, what do you think would be optimal drugs that you would like to start a patient who has obesity with concurrent type 2 diabetes and so and probably with a concurrent hypertension? What you would like to start him on, and what optimal drugs that you would like to prescribe such a patient?
I think I'd already briefly mentioned in my last question, but in terms of the management of diabetes, how it has kind of changed from just the glycemic control. So apart from just the cardio and renal benefit, there is a class effect of the SGLT2 inhibitors when you talk about for the heart failure as well as the progression of the diabetic kidney disease. You can use as a combination with metformin, or you can use as a monotherapy. But ultimately, because we see people with, you don't see average of 6.5, 6.7 people coming to us. They will be usually 9.5, 10, or even 11. So generally, you would require combination therapies, and majority more or less would require a combination of a metformin and SGLT2 inhibitors. And again, if compliant and if they are ready to, I think if they're affordable, I think GLP-1 analogs are there. And today we have the option of giving the long-acting, the weekly ones, GLP-1 analogs, either the semaglutide or the tirzepatide, which is a dual receptor, GLP and GIP. With my personal experience, I think the dual ones are slightly the withdrawal and the stopping the therapy has slightly come down. The GI issues are slightly lesser, though I may be too biased at this point. But when it came compared to the oral semaglutide or even the injectable semaglutide, mainly because of the difference in both of them, the dual receptor is more GIP than GLP. The other thing is, again, optimally utilizing the dose of metformin is also very important. Metformin, though, is we tell it as weight neutral. They again do well in combination with these therapies. And again, not only just the weekly GLPs. Today, people with cost issues, we have still the older biosimilars are available, liraglutide, which can be used on a daily basis. But with any GLP-1 therapies, the biggest advantage here is the cravings comes down, because there are a lot of people who complain saying, doctor, we try to do it, but there is always this craving to eat, and the pleasure eating comes down, the satiety also comes down. and some of the non-glycemic benefits in terms of the blood pressure, decrease in even in the urine albumin creatinine ratio. Even there are a lot of trials to show with the ACVD benefits with this molecule, the plaque stabilization, as well as the progression has been seen with the GLP-1 analogs. And we have very kidney-specific trials also. Apart from the cardiovascular trials, we have had the kidney-specific trials like the FLOW trial with semaglutide, as well as there are even people without diabetes. There is a SMART trial which is going on. So, and also for the MASLD, fatty liver is another important component of obesity management. And all these drugs kind of have a favorable benefits even on the liver, heart, kidney, and therefore definitely has a beneficial effect even in your glycemic control in the long run.
I think that's a beautiful summarization of the things that we discussed today. So I think first we started with discussing the pathophysiology per se of obesity, and we spoke a little bit also about what obstructive sleep apnea entails and what are the clinical implications of this obstructive sleep apnea. We also spoke or talked in detail about what are the implications of obesity, and this actually truly believes us that obesity is a chronic multi-system disorder. So it's not just one system that is being affected, but it's multi-systems that are being affected, right from the bone to your gonads, to your kidneys, to your heart, to your metabolic profile, to your endocrine system, to your thyroid system. Each and every system, one way or the other, is implicated whenever you have associated obesity. Then we spoke about what obesity entails or the treatment in obesity entails, where I think moderation is an important key. Dr. Krutika also spoke about something called as keeping a balanced diet, and Dr. Vikram Patil, he spoke about mentioning that we need to keep smaller targets, and patient needs to focus on achieving those smaller targets first, and keeping consistently in achieving these targets. And I think Dr. Praveen Gangadhara elaborated more about drugs that are available like metformin, SGLT2 inhibitors, incretins like GLP-1 analogs like liraglutide as well as semaglutide, as well as double incretins, that is tirzepatide, which is available. After that, I think Dr. Kritika mentioned about treating most of the hypertensives with either with RAS activity like drugs or with drugs that are associated with non-steroid receptor agonist drugs. And also, Dr. Vikram Bhatt explicitly spoke about treating each and every patient with obesity and ischemic heart disease with dyslipidemia. So dyslipidemia needs to be targeted, and statins need to be used in most of the patients. And I think this is an important take-home message over here that we need to carry forward. So I think I would like all of you to, before we conclude, a last one pointer that you would like to tell patients as well as physicians who are treating obesity, what you would like to tell them, and yeah, in short, what you would like to recommend them to treat obesity in their patients. Kritika, please.
Yeah. So my take-home message is among all the risk factors or all the components or entities of metabolic syndrome, I think obesity is the one which is most modifiable, which is in our hands, and we can do it. So provided we are motivated and given the right guidance, I think it is one of the easily avoidable factors. So that needs to be kept in mind. And secondly, to create awareness about doing a kidney test in terms of creatinine and identifying the GFR serially, and a simple urine test to look for the proteinuria, which needs to be done by the treating physician till they come to a nephrologist.
Yeah. So, and Dr. Praveen, would you like to give a small message to patients,
I'm
physicians who are
happy.
treating
Before I
obesity?
start, I'm happy to hear that from Dr. Kritika. So I would not see if there is urine routine, I require a urine albumin creatinine ratio or a retina evaluation,
Yeah,
Right.
that's great
especially
actually.
in type 2. So we make sure
Right.
that you screen, and ultimately treatment management depends. Somebody comes with not even a serum creatinine with a fasting PPI. Say, sorry, boss, I'm not the right doctor for you. Probably you can carry on. And the refusal to prevent these certain basic things are extremely important. And Vikram sir would agree getting an ECG or in getting an annual echo evaluation in high risk cases, because complication workup is something our people take it in a very pinch of salt. And we give statin for a primary prevention 10 milligram. They'll play around with all sorts of
True.
experimentation, and 40 milligram finally post PTCA they would swallow it like chocolate. So that's one challenge we all face in our practice. I think the take home message is simple. I think It's not a one day story or it's not a 2020 match. Obesity managing each one is different. I think you need to start slow and things about what works out for you. I think sustaining the goals is very important. To have realistic goal is also very important. Don't be too hard on yourself. A lot of people, especially with the advent of these newer drugs, they expect, doctor, what can I expect with 5 mg? What can I expect in 10 mg? And directly proportional to how much you pay. So you need to have realistic targets. It's all about how much can you sustain, and how can you will plateau at some point, but definitely 10 to 15% of weight loss has shown benefits across cardiovascular, renal, even your glycemic benefits. So, and not to forget the diet, and no shortcuts in the diet in terms of either keto diet or a extremely low carb, and don't go into any of the extreme mode. Yeah. Thank you.
And I would like Dr. Vikram to also give us take-home message. So, what do you think that physicians should carry home when they hear to this talk about obesity? So, any more points that I think Dr. Kritika or Dr. Praveen you would like to make regarding obesity and treating its implications? Probably, I think
Dr.
Dr.
Praveen, you can say first.
I think more or less we have covered. We have had a kind of a healthy discussion across in
Absolutely.
terms of the management, and very beautifully illustrated with each specialty there. And I think treat obesity just not like any other chronic diseases, and probably when you treat this, more of the other comorbidities also can be taken care. And people will definitely agree that when the target weight loss of 10 to 15% from their baseline definitely improves parameters across. Whether today there's a lot of talk about remission of diabetes, and we know that the thyroid subtype and that is the insulin resistant obese type 2 or the mild age related diabetes, who generally tend to have a good beta cell function. Here the healthy weight loss is kind of a gift for you. You can achieve remission, but you gain weight again, you will get it back. So it's not called reversal. Remission is the correct word.
So that's an important point that you have made over here. So I think with this we end our this session of 4D 3.0, where we spoke in detail, discussed in detail, had a dialogue about Indian diabetics. And with this, I would like to end this session. I would like to wish you all thank you very much for the
Thank you,
enlightenment.
Dr. Ashpal. Thank
Sure.
you, Dr. Kutikar. Thank you, Dr.
Yeah,
Vikram.
Thank you.
thank you. Thank you, Dr. Yashpal, specifically.